Hello everyone, my name is R.H. Zderhi, and I'm a second-year internal medicine resident at the University of Alberta. On behalf of my team, led by Dr. Jennifer Jacquier, I'll be presenting a case of ectopic Cushing syndrome secondary to medullary thyroid cancer. We have no relevant disclosures to declare. We will discuss ectopic Cushing's as a complication of medullary thyroid cancer, as well as some of the targeted therapies that have been used not only in the management of medullary thyroid cancer, but in reversing associated Cushing's as well. Medullary thyroid cancer is a rare neuroendocrine tumor of the thyroid gland that is associated with activating mutations of the rearranged during transfection proto-oncogene in all inherited cases and up to 60% of sporadic cases. Rarely, these cancers may secrete ACTH or CRH, resulting in a paraneoplastic Cushing's picture, and this is seen in roughly 0.6% of cases. Management of paraneoplastic Cushing's has been difficult given the lack of response to conventional medical treatments for hypercortisolism. Our case involves a previously healthy 37-year-old male who presented with primary complaint of abdominal discomfort and was found to have a large left-sided neck mass on exam. At the time of presentation, he reported several symptoms of hypercortisolism, including a new rash on his torso and shoulders, which is pictured here. Ultrasound revealed a left lobe mass with multiple abnormal appearing lymph nodes, suspicious for malignancy, and indeed biopsy of the neck mass was consistent with medullary thyroid carcinoma. Further workup revealed metastases to the superior mediastinal lymph nodes, liver, and spleen, which was confirmed with biopsy. His initial blood work revealed elevated calcitonin and CEA with normal calcium and PTH. Random cortisol, ACTH, and 24-hour urine cortisol were elevated, with dynamic testing showing a lack of suppression with high-dose dexamethasone. His presentation was in keeping with metastatic medullary thyroid cancer with associated ectopic Cushing syndrome. Genetic testing was negative for germline RET mutation and positive for somatic RET mutation. Given the presence of metastatic disease and positive RET mutation, he was started on vandetanib, a multi-target tyrosine kinase inhibitor. 2 weeks following initiation, blood work demonstrated improvements to 24-hour urine cortisol, and imaging demonstrated decreases in the size of the thyroid and metastatic lesions. Roughly 10 months after initiating vandetanib, however, increases in size to the liver metastases were noted, as well as elevations in calcitonin, CEA, and cortisol. Given the evidence of progressive disease, vandetanib was discontinued and he was started on the RET-specific inhibitor selpercatinib. This was followed by rapid biochemical improvements after just 5 weeks, and repeat cross-sectional imaging showed decreases in tumor size. At this time, he complained of worsening fatigue, and cortisol was at the lower limit of normal, so he was started on hydrocortisone replacement. We can see here the decreases in size of the left upper prevascular lymph nodes on the left and the left subcarinal lymph nodes on the right. Vandetanib and cabozantinib are multi-target tyrosine kinase inhibitors that have demonstrated efficacy in the management of paraneoplastic Cushing's, even in cases of treatment-resistant hypercortisolism. Their use, however, is limited by adverse events and the development of resistance. Selpercatinib is a newer, RET-specific inhibitor that may overcome some of these limitations. It has been shown to produce response in patients who have developed resistance to other tyrosine kinase inhibitors. RET-specific inhibitors like selpercatinib have only been reported to reverse paraneoplastic Cushing's in several cases, however. Lastly, our case highlights that tyrosine kinase inhibitors may be associated with adrenal insufficiency. The mechanisms underlying this are unclear, but this finding may warrant periodic ACTH stimulation testing to assess for subclinical adrenal insufficiency within this population. Thank you for listening.